welcome back to another edition of the Heart to Heart podcast. And I've never done this before, but I do think my guest today actually doesn't really almost need to be introduced. It's Dr. Ethan Russo. He's the godfather of cannabis. Everyone who knows cannabis knows exactly who he is. He's the CEO and founder of Credo Science. He's also a neurologist, been in the space for over 30 years. So Dr. Russo, it's an absolute pleasure and welcome to the show.
Thanks for having me.
Well, I'm really excited to chat with you today. You're probably part of the reason I almost started my podcast. I wanted to be able to reach out to guests like yourself. And, as I say at the beginning of the show, everyone in the cannabis space knows who you are. I think you've got, how many published papers do you have on cannabis, Dr. Russo?
Somewhere north of 60 at this point.
Yeah, so probably more than anyone else. I've certainly read quite a few of them before. I think you were the first person to really coin the term entourage effect. Is that correct?
Not quite. I mean, I can claim to have popularized it with respect to cannabis, but yeah, that actually goes back to 1998. Professor Meshulam and Ben Shabbat described it. Thought that was muted.
It's okay.
Sorry. Yeah, in 1998, Professor Meshulam and Ben Shabbat described the entourage effect in relation to endogenous cannabinoids. The idea that 2-arachidonoglycerol and anandamide worked a certain way, but seemed boosted in the presence of other related molecules that on their own seemed inactive. And the next year, 99, they pointed out that this could apply to medicinal plants, plants being better than single components derived from them. And it's a concept I've tried to run with ever since. And there's a tremendous amount of background science and clinical work now to support the idea that there's synergy, a boosting of effect between different components in cannabis.
Okay, sure. So, yeah, that's probably a good place to start is with the entourage effect. So, for people who are unaware of the entourage effect, basically, what that means, and Ethan can correct me if I'm wrong, is that essentially most people, a lot of scientists feel that you would benefit more from using cannabis if you get all of the cannabinoids and all of the terpenes versus, say, just isolating one terpene or one cannabinoid. But I'll let you explain that a little bit better than I did, Dr. Russo.
Sure. Well, that's the basic idea, certainly. Most people have probably not had the experience of using THC in isolation, like Marinol, which was approved by the FDA in 1985. But it's really nothing like cannabis. THC on its own is a very hard drug to tolerate. It's apt to produce dysphoria, unhappiness, rather than euphoria, and it's very disorienting. It needs these other components of the herbal plant to tame it, if you will. So there are many components, including cannabidiol, limonene, caryophyllene, and pinene, that change its character to make it a more acceptable medicine. Technically, we call that increasing the therapeutic index. In other words, being able to use a higher amount of THC and have the person still tolerate it so that they can treat their condition.
Yeah, I think that's a really good point too. And that's something that I try to discuss sometimes with my patients on this podcast, that you have some patients or some people that will try THC, a high dose of THC, whether it's through, flower, whether it's smoking it or through ingesting it through an oil or a gummy or what have you. And it's basically, pure THC or very, very close to pure THC, and they'll have a very poor experience. And then because of that, they'll more or less dismiss cannabis altogether because of that. They won't want to try CBG, they won't want to try CBD, they won't want to try anything else. And I think that's where we lose a lot of patients in this process, is because they've had that really poor experience with THC, but unfortunately, they didn't get an opportunity to try maybe a lower amount of THC with CBD or maybe just CBD on its own. But I do feel that a lot of patients do benefit by using both of the cannabinoids together. And by both cannabis, I'm talking about THC and CBD, but other cannabinoids are beneficial as well, obviously. But those are the two big commercially available cannabinoids that are available in Canada now. We're going to talk a little bit about some other ones that have become more commercially available, but those are the two big ones. And I think that it's unfortunate that some people, when they have that poor THC experience, then they kind of dismiss cannabis altogether. Is that something that you've kind of encountered in your over your lifetime?
That's a huge pitfall, and it's got to be avoided at all costs. By the time someone gets around to using cannabis to treat a medical condition, they've been through the gamut of conventional medicine. And if they have a bad experience straight out of the chute because of too much THC, they've really lost the opportunity to improve their situation. So, what we really advise is balanced, full spectrum products, and beginning extremely slowly. The buzz phrase is start low and go slow on any increases in doses. Because again, when a person has that one bad experience, that may be the end for them.
Yeah, I've definitely seen that in my practice, and I'm glad that we're discussing this today. So, again, for people listening, if you have had, a poor experience to, THC, don't throw out the baby with the bathwater, so to speak, and make sure that you do look at the whole plant. You may actually have a very, very, different experience just by using another cannabinoid, or at least, a different combination of cannabinoids.
Sure, and just to highlight that, THC is just one of at least 150 phytocannabinoids, cannabinoids from the plant cannabis. And there are some 200 different terpenoids that have been found in cannabis. So one preparation is not like another, and again, the full range of the therapeutic properties of cannabis have barely been explored by most people because all the bandwidth has been taken up by THC and now CBD.
Okay, and that's just something that I want to chat with you about today. So one cannabinoid that I've been very interested in, and I was writing about it maybe 3 or 4 years ago, but I kind of just stopped because I think it frustrated people that I was writing about this wonderful cannabinoid and then they couldn't access it. So the one that I'm talking about today is THCV, and the reason why I was so interested in that particular cannabinoid was because I've seen one clinical trial anyway indicating that it can actually reduce your need for insulin and can lower overall blood sugar. And it would be helpful for patients with type 2 diabetics, and it can actually reduce your appetite as well. So, this sounds like this incredible cannabinoid. I mean, a lot of people struggle with, keeping weight off. And I was just wondering, why has this cannabinoid not been, pushed or isolated commercially like CBD has?
Sure. Well, it's beginning to happen now in the US, but not in a really controlled fashion. So it's a combination of factors. One is the continued barriers to research. Additionally, our scheduling, particularly in the US, meaning that technically still could be considered a Schedule I forbidden drug. In Canada, I've got to be really critical of the licensed producers. They could have been on this bandwagon a long time ago and just haven't chosen to do it. Perhaps it's something they haven't understood. They certainly haven't understood the market opportunities, because this is a fascinating molecule. To explain, tetrahydrocannabivarin, or THCV, is an analog of THC. It's got a 3-carbon side chain instead of 5, and it acts quite differently. It's what's called a neutral antagonist at the CB1 receptor. That's the psychoactive receptor that's responsible for a lot of the brain effects of THC. So a neutral antagonist means that if it's used in conjunction with THC, it's going to change the character a little bit. It will blunt the peak high. People use them together, notice a clearer high, maybe a quicker onset and a quicker offset. But what you mentioned is the real value here, among others, is that THCV curbs hunger also has in humans and in animals has been shown to reduce the effects of the metabolic syndrome, where people who are obese develop insulin resistance and are often on their way to developing type 2 diabetes. And that's a lot of people in North America. As the world goes, we're a population of increasing girth. That's a nice way of saying that North Americans are getting fatter by the year. Too much poutine north of the border, I think.
Yeah, way too much, I think. We, being from Newfoundland, poutine's actually probably one of the most popular dishes out there. So I think we definitely, unfortunately have, consumed too much food. We're just over consuming, calories in general, and I think that's why,
Well,
kind of gotten
in
to
the case of Newfies, I'm sure it's with a chaser of a couple of pitchers of beer. So
yeah, we definitely like our screech and our beer. That's definitely for sure. But just coming back again to the THCV. So Ethan, do you feel that it may in fact in the future be commercially available, or do you see that right now it's just still a slow process, and that it's probably going to be months or years before someone can get it off the
it's
shelf?
showing up in the US, and certainly we're trying to develop better cultivars that are richer in THCV and with decreasing concentrations of THC. And I should mention, this isn't just for diabetes and the metabolic syndrome, but THCV has also been shown to help with neuropathic pain, nerve-based pain. It has anticonvulsant effects. It may be a useful adjunct in treating addictions. So there are just a whole list of reasons why this should be one of the next big things.
Yeah, I mean, just the list of conditions that we're, talking about now, like traditionally, I feel like cannabis has been associated with insomnia, pain, and basically mental health. Those are more or less the bigger ones that people are using cannabis for. But I'm very interested in using cannabis for other medical conditions. One of the ones I guess it's most popular outside of the ones that I just mentioned is epilepsy, and CBD has been shown to be pretty effective for that. But like you mentioned at the start of the show, like there's over 150 cannabinoids, and we're just kind of starting to realize the potential of these individual cannabinoids. And so we will be able to treat things like diabetes and metabolic syndrome with cannabinoids in the future, like THCV. And another cannabinoid that I wanted to chat with you about today, Dr. Russo, was CBG. And the reason being is because that is fairly commercially available in Ontario anyway. You can get it on the OCS store, and I think several of the licensed producers are carrying that particular cannabinoid. I know there's not a whole ton of randomized control trials on humans using CBG, but in terms of CBG, what do you feel that it can be used for best, and how do you see it being used therapeutically for patients?
Sure. Well, just again, to give some background, CBG was discovered clear back in 1964, again by Professor Mechoulam, same year that THC was figured out. And they recognized it then as the precursor, the mother of all cannabinoids, if you will.
Okay.
Normally, the plant doesn't make a lot of it. It doesn't stop there. It goes on to the other downstream molecules like THC and CBD. However, in recent years with selective breeding, some natural mutations in the plant that lack the enzymatic equipment to go on to THC and CBD have been discovered. So these plants will make a lot of CBG, cannabigerol. So this is a totally different profile. This is a non-intoxicating cannabinoid, but it has a really profound effect on anxiety without sedation or without any hint of dependency. So this is quite distinct from what conventional drugs for anxiety do, because most of these are going to be sedating or downright addicting, particularly the benzodiazepines, Valium et al. So this is quite different. And this really may be one of the solutions to the ills of modern society. Last year, our team published the first real study of CBG use in humans. So we had, it was a survey, but 127 people who were using material that was at least 50% CBG content. And the results were really striking. People reported this extremely helpful for pain, for sleep disturbance, for anxiety and depression. But there were about 26 other medical conditions where people reported improvement. And nobody in the survey thought that conventional treatment of these disorders was superior to the effects that they got from CBG. Additionally, nobody reported any particular major side effects, no withdrawal effects when they stopped it. So it's really a remarkable profile for an agent in development, let's call it. I really think that this will be a tremendous adjunct addition to current preparations and really extend their benefit.
Excellent. Yeah. So that's really good to hear because, on like we just mentioned, THCV unfortunately is not commercially available, but CBG is. So, for people who are listening, you can in fact, obtain this cannabinoid, and, the conditions again, Dr. Russo, seem to be insomnia and depression and anxiety that CBG seems to help with. And then I know there was one study, it was done, I think, in mice, or maybe it was done differently, but it looked at all the different cannabinoids, and it said that CBG seemed to be the best for bladder control. I was just wondering if you can speak on that a little bit, because I know that there's a lot of people who struggle. I mean, I'm kind of one of them, that I'm pretty young to be getting up and peeing at least, once a night,
Well, we wouldn't want to promise too much, but yeah, there's a scientific reason behind this. Among other things, it should also mention CBG has marked antibiotic effects against gram-positive organisms, including antibiotic-resistant things like methicillin-resistant Staph aureus and vancomycin-resistant Enterococcus. But it also, of the cannabinoids, is the strongest as an antagonist of what's called the TRPM8 receptor. That's a receptor that's involved in prostate cancer. It's also involved in bladder conditions. And so the likely explanation for the improvement in bladder function is its effect on this receptor. And again, the anti-anxiety effect helps too. A lot of people will urinate more when they're nervous. So it could be at least two different mechanisms there.
Very, very interesting. Yeah, I've heard that before too, that some patients will just, they tell me that, when they're nervous, they tend to pee more. It's just kind of, something gets ingrained into them, and then that becomes a habit. So, having something on board like CBG, again, we're not making any claims here today, but, there is some preliminary evidence to suggest that it absolutely can help with, bladder conditions. So, I do think it is reasonable to use that for that particular condition, if you're struggling with it. Any research, or is there any evidence that the combination of CBG and CBD may be more effective, say, than just CBG or CBD alone, particularly for the treatment of anxiety?
Yeah, quite possibly, but there haven't certainly been any randomized controlled trials to demonstrate that.
Okay. Excellent. So one question I want to ask you today, people are still using the terms sativa and indica all the time. And, just from the way that you're looking at me now, I think that you think that we should not be using these terms, and they should, be thrown out. We should have new, nomenclature introduced into the cannabis industry. So, why were those terms first introduced, and why do you think that they should be phased out now?
Okay, well, again, let's back up. Let's go back to the 18th century. Linnaeus was the guy that developed the Latin binomials, the two naming system for plants and animals. So he assigned Cannabis sativa, cultivated cannabis. He didn't originate that name. As far as I know, it was used at least 250 years earlier by Leonhard Fuchs in Germany. But anyway, he was the one that systematized this. About 25 years later, still in the 18th century, there was this guy named Antoine Lamarck in France, and he described what he thought was a different species from India that he called Cannabis indica. Now, as opposed to the European hemp, which was a tall, spindly plant with thin leaflets, this was a bushier plant, also with thin leaflets. There's been debate ever since if there really is more than one species. But the problem was in the late 60s and 70s, people got on to cannabis from Afghanistan. And this is a totally different looking plant. They're squat, only about a meter high, and they have very broad leaflets. And this is clearly morphologically, meaning the shape, how it looks is quite different from either Linnaeus's Cannabis sativa or Lamarck's Cannabis indica. Now, what's happened in modern parlance is that people will say that sativa is a head high and indica is a body high. This is nonsense. There have been any number of scientific papers that have looked at the composition of things and shown that you can't tell anything by what the plant looks like and what one person calls an indica and another person will call a sativa. And there's been so much crossbreeding that it's totally confused. What we should be talking about now are chemical varieties, chemovars. This is the term I prefer. So this would be the idea that we have a good certificate of analysis on the plant or the preparation that you're buying, and you'll know exactly how much THC, CBD, other cannabinoids, and terpenoids there might be. We need to know the profiles of things. And this is the way in which people would have a good idea of how this preparation might affect them. So, you know, if somebody is taking a cannabis preparation for sleep, it requires one profile. If, on the other hand, they have chronic pain, but they have to work or study during the day, a totally different profile may be necessary. So again, if science can come into it, we can have a better understanding and description of what people are buying or taking. But these practices that are currently applied are nonsense, and they should be abandoned.
Yeah, I think that it's confused a lot of people because they, you know, I mean, we do tend to look at things in black and white, and unfortunately, you know, for cannabis patients, I think that is not a good way to look at things because, you know, if you just say, okay, if I use high THC, this is going to put me to sleep. That's not always going to be the case. You know, it may in fact kind of make you wired, make you feel a little bit paranoid. And, you know, just because you're using something that's a sativa, that's not, you know, necessarily going to like energize you, you know. So I think it's important for people to know that. But that being said, Dr. Russo, so how do people go about, you know, selecting a product that say would be more sedating and selecting a product that would be more energizing? Like what would be the things that you would look at?
Sure. Well, some basic concepts. Again, most preparations are going to have THC in them, but the amount matters. It also matters whether the person is used to it, whether they have a tolerance, or what their underlying endocannabinoid tone is, which means, you know, how much endogenous cannabinoid is floating around in their brain. But that's not something we can easily measure at this point. If there is CBD aboard, it is going to blunt the peak high and delay it. So it'll be slower onset. It also lasts longer. So that's a factor. And then CBG again can help reduce or eliminate some of the sedation from THC. If there's pining on board, that is going to reduce or eliminate the short-term memory impairment from THC. So, what's good on Friday night, if you're trying to forget what a jerk your boss was, it's good to have a little THC then and forget and laugh about, the ridiculous situation at work. On the other hand, again, the medicinal patient who has to function doesn't want to be forgetful and doesn't need to be laughing. So quite different. And then the whole terpenoid profile comes in. And this is what really makes a difference. Pinene, again, reducing the short-term memory impairment. Linalool as an anti-anxiety agent. If somebody wants to sleep, having myrcene aboard with the THC is really going to help sedate them. It's what I like to call the couch lock factor when combined with THC. So there are all these different combinations, and the only way a consumer has a chance is if they've got that certificate of analysis in hand, not on something that these guys made 6 months ago, but on a current batch of what they might be purchasing. So again, a lot of this has to do with standards in the industry and a need for them to be much more rigorous.
Yeah, I mean, I think we've come a long way since we've started, but I don't think we're, nearly where we should be. And I don't think that, patients really have, all the necessary information that they need when they're, selecting a particular product, because, unfortunately, the products that they're selecting from don't have all of the things that need to be on there in order to select a product. So what I mean by that is, for sure, there's been, they will list the cannabinoid content. Sometimes they will list the terpene content, but oftentimes what they do is they don't list the terpene content, and when they do, they don't tell you the exact amount. So they'll just put it as like the very last ingredient, and it might be in like a gummy, and that could have, a bunch of different, food ingredients in addition to the medicinal ingredients. And then at the end, you're just left with, that also has myrcene or also has linalool, or you really have no idea. So if someone is, say, consuming, 10 milligrams of THC, just as an arbitrary number, how many milligrams of myrcene do you think would have to be matched in order to make that THC sort of into a more of a sedating effect or experience for the patient overall?
It wouldn't have to be a lot. The terpenoids are very potent. So, we can see terpenoid concentrations totals that are about 20% of what the cannabinoid content would be. So in other words, if there were a flower with 25% total cannabinoids, exceptionally, we might see 5% terpenoids, but it often is lower, much lower, on the range of 1%. So with the 10 milligrams of THC, even 1 milligram of myrcene is likely going to be sedating. And if it's higher than that, it's likely going to really knock people out. Yeah.
Okay. And then I know too that, I'm not sure how good these sources are. I've had, just one or two patients. It was actually a while ago now, and I didn't get to chat with them again, unfortunately, but they were asking me about some terpenes that they found just on Amazon. I forget the exact the name of the company, but they did produce terpenes, and they were asking me about it. And unfortunately, at that time, I just didn't have the knowledge really to indicate to them how to use it. And then unfortunately, because of the product was just something from Amazon, I was kind of unable to really give them a good clear answer. So I'm just not sure if you've had anyone isolate terpenes or ask you about a particular terpene, but are people using these on their own, or are they using these only in conjunction with cannabis?
Well, people have to recall terpenes are derived from essential oils that plants have. So they've been around a long time. The real pioneering in aromatherapy was done by the French over the last 100 years or so. But yeah, there are preparations available. I would have people be very careful. The main source of terpenoids are from petroleum distillates, and they're not designed for human use. So if someone's going to do this, the terpenoid should be in the form of a good quality essential oil, or from a company that is using them botanically derived, in other words, from a plant, and ideally cannabis derived, meaning from cannabis and not from something else. I can say that the company True Terpenes in Portland, Oregon, is moving in this direction. They currently have botanically derived terpenoids of high quality, and they are developing a process to provide cannabis-based terpenoids of all kinds. But again, people have to be extremely careful and do a lot of detective work. It's not a simple thing, to get brand X and hope that it's going to do the job or be safe.
Okay, and then just with regards to terpenes, just some basic education for people listening. So myrcene is probably be the one that you think would be the most sedating and would be the best for sleep. Is that correct?
Well, not necessarily the best. It is the most sedating.
Okay.
But there are a lot of reasons that people don't sleep. It can be due to pain. It can be due to anxiety. It can be due to rumination, thinking about all the bad stuff that happened. It can be due to restless legs. So depending on what you're treating, different things may be called for. But in general, a little bit of THC, like you said, too much THC, people are going to get too high or paranoid or have eyelid movies or something that's going to interfere with them getting to sleep. The key is a little bit. People overemphasize CBD here. CBD on its own is not a sleep aid. It's actually stimulating. At extraordinary doses, yes, it could be sedating. But at low doses, it's normally stimulating. It might be helpful in small amounts, again, to reduce anxiety. But I think that CBG would be better because this is not going to have drawbacks. It's not stimulating. It clearly is anti-anxiety. And then again, the terps come into play. Linalool can be really helpful as a sleep aid. It'd be in common to cannabis. Linalool is found in lavender. Lavender is well established as a sleep aid, particularly if there's an anxiety component involved. So those kinds of things are really going to be helpful.
Okay, yeah, it's interesting that you mentioned lavender, because that's another essential oil that a lot of people use, and it's probably one of the more popular ones that people use. And I know that I'm a big fan of the website examine.com, and they have some research on lavender, and they indicate that when it's combined with lemon balm, sometimes it can provide a very sedating effect. So it doesn't necessarily always have to be cannabis to put you to sleep. Sometimes you can combine cannabis with some of these other natural health products to assist with
Yeah. Well,
sleep.
yeah, I mean, I certainly can recommend people can try simple legal things first, like having an aromatherapy diffuser. So a couple of drops of lavender essential oil or neroli, which is more expensive, but it has a good amount of linalool in it, and actually a much more pleasant scent. Neroli is made from orange flowers. But yeah, that's a great one for sleep.
Yeah, I mean, I got actually a little bit of just peppermint oil here. I'm not sure if you can see it, but I've used that for headaches for a few years, and I mean, it's quite remarkable how potent it is because like it's instant. Like if you take a Tylenol or an Advil or something, you know, and I mean, don't get me wrong, a lot of those medications can work for people with headaches, but you know, you're looking at for sure 15-30 minutes, maybe longer before you get the full effect. But when you're looking at something like peppermint oil, you know, it can be effective. I mean, I don't want to say on contact, but it's pretty close to it. You know, it's definitely within seconds to minutes. And I know that I saw at least one study, I think it was in the early or mid 2000s, where it compared peppermint oil to two extra strength Tylenol. And it did indicate that peppermint oil was as efficacious or maybe even more efficacious, either as or more. I can't remember which one. So, you know, definitely essential oils do have, you know, some evidence for some, you know, therapeutic effects, you know, whether it's headaches or something else. So, you know, they are good medicines. Um, you know, another thing that I wanted to, or another cannabinoid that I want to chat with you about today, because it is, you know, more commercially available, and you know, so many people do struggle with sleep. We've talked a lot about sleep today, but the big one that I've seen, you know, people chat about is CBN. You know, a lot of people do think that it's overhyped, and then other people say that, you know, it's just as good as THC. You know, what are your kind of thoughts on CBN overall, and is it efficacious for sleep?
Sure. So yeah, first, what is it? Cannabinol. CBN is an oxidative breakdown product of THC. So if you have old cannabis, the THC is going to degrade into cannabinol. What you can say about it is that it's about a quarter of the potency of THC. It's more stable than THC. However, it's hard to really figure that it has any specific advantages. It might in jurisdictions where people are only interested in the legality of THC and they can use CBN instead. But as a sleep aid, there was an excellent review by Corrin, Corrin, that was in Cannabis and Cannabinoid Research last year. In this study, they looked at all the information on cannabinol as a sleep aid. Basically, it comes up short. Everybody's putting this in their sleep preparations, but its evidence for efficacy is really lacking. That doesn't mean it won't work, particularly if there are other ingredients, but I think the hype is really, there's more, the signal to noise ratio is out of whack on this one. Again, it has some beneficial attributes, but it isn't, it's a marketing ploy for the most part. The real attraction of CBN to the big time producers is when they've got old cannabis that can't be otherwise leveraged economically, they can extract CBN from it and sell it to somebody. Yeah, hate to put it in mercenary terms, but that's the main reason that people are making CBN.
Well, we want the truth, and you know, I'm glad that you're giving it to us today, and I'm sure people listening too want to know that as well, because you know, people who are struggling to sleep, you know, they'll basically do anything to try to get to sleep. So, you know, I could see how, you know, it could be an effective marketing, you know, tool, because you know, it's like, hey, this is, you know, old cannabis that's been degraded, and you know, it's been shown to be effective for sleep, so people are going to jump all over that. But unfortunately, you know, from our discussion today, it doesn't seem like the research matches the hype. That being said, is CBN effective for any other conditions that you believe?
Well, like the other cannabinoids, it has some of the same attributes. It has some effects on infectious agents. Again, if you had enough of it, it could have an intoxicating effect. But anybody who's used cannabis that was past dates knows that it's not usually very exciting. There may be sedation, but it isn't so much from the CBN. It's the fact that all the lower molecular weight monoterpenoids have vanished, and what you're left with is sedating sesquiterpenoids, higher molecular weight compounds. So again, this is one of the sources of the misconceptions, because people will say that, well, you know, I had some old cannabis I found in the drawer that was 5 years old, and I smoked it and it made me sleep. Well, I mean, that's the best thing you can say. Nobody's going to say they enjoyed the experience. So yeah, again, more hype than benefit.
Okay, so I've asked you, you know, about CBG. I've asked you about you know, a couple other cannabinoids as well. You know, THCV. Is there any cannabinoid that we haven't discussed today that you think is going to become commercially available soon, or any cannabinoid that you think is you know, really going to disrupt the market and help a lot of people?
Well, less the latter, but certainly mention the acid cannabinoids, THCA and CBDA. So these are what are present in the fresh plant before they're decarboxylated to THC and CBD respectively. THCA has a lot of benefits on inflammatory conditions and autoimmune conditions. And again, there's science behind this. It works on two things. It works on the PPAR gamma receptor, which is involved in nuclear transcription, and it can be useful in obesity and treating cancer. And then it also is an affects tumor necrosis factor alpha that's involved in a number of inflammatory and autoimmune conditions, like rheumatoid arthritis and inflammatory bowel diseases. With CBDA, it actually is much more powerful on the serotonin 1A receptor as compared to CBD. So it could be useful in treating nausea, on perhaps anxiety, although I really haven't seen that borne out clinically. Both THCA and CBDA have been used as adjuncts, additional materials to help try to gain seizure control in epileptic patients. But again, some of this is anecdotal at this point. We certainly have colleagues in US and Canada that are using these agents to advantage to treat their patients, but it is the case that we don't have the more formal randomized controlled trials to show the utility of these compounds. What I can say is they seem to be very safe. People have been using raw cannabis, whether European hemp or you know, the Asian cannabis that would have THCA in it. These have been used for thousands and thousands of years and commonly in foodstuffs. So the safety factor certainly seems to be there.
Very, very interesting. Yeah, I've heard quite a bit about THCA and CBDA, and you know, hopefully we'll have more, you know, randomized controlled trials in the future, so that, you know, we can you know, help more patients with more conditions. You know, that being said, Ethan, another thing that I want to ask you about, I know we did chat about CBD already, but the big thing about CBD is the doses. And, you know, this confuses a lot of people because, and I remember too, even when I, you know, first started looking at CBD, I was looking at these studies and I was like, holy crap, they're using like 300 milligrams or 600 milligrams of like CBD. Like my patients are taking like 10, 20 milligrams, sometimes less, and they're still seeing
paying for it in either event.
Yeah. So like, I'm just wondering, you know, like, where did these studies come from and how did they come up with, you know, 300 milligrams, 600 milligrams?
Well, unfortunately, that's what's needed when you're using CBD as an isolate. So
Okay.
we really have to make a distinction. CBD is a very safe, very versatile therapeutic agent. However, what it is not is very potent. So on its own, And the prime example is Epidiolex, a 97% pure CBD preparation derived from cannabis that's approved in various countries for treating severe epilepsy syndromes. Typical dosage is 1,500 milligrams a day or more, depends on the person's weight, etc. We know from a very careful study called a meta-analysis by Pamplona et al. That the same conditions can be treated apparently as well with doses that are about 80% lower when there are other components involved. What I like to say is there's nothing that CBD does that won't be enhanced by at least having a teensy bit of THC aboard. And certainly, again, terpenoids and other cannabinoids. Again, the same thing is true. There have been 2 phase 2 clinical trials of pure CBD in 800 milligrams and 1,000 milligrams to effectively treat schizophrenia. However, obviously that gets really expensive. The good news is that it worked well and was well tolerated, but somebody's got to pay for all this stuff. Lower doses of CBD can be effective, but again, much more effective if it's a full spectrum product rather than isolate. So that's the difference.
Okay. Yeah, because I know that definitely confuses a lot of patients because and doctors too. Yeah, for sure. Because they see like, holy crap, in these studies, they're like 300 milligrams, but like my patients are taking 10 and 20 and they're saying that they can feel it. Like I kind of feel, uncomfortable increasing it by literally like 30 times,
Well, again, if the patient's benefiting, there'd be no need to go for the lofty doses.
Yeah, I totally agree with you on that. And I mean, everyone is different, but from my clinical experience, I find that a lot of patients benefit, from around 20 milligrams seems to be like a good dose for, and sometimes even less. But most people will feel, at least not all the time, but they generally do feel at least something, I find, with about 20 milligrams, whether it's a reduction in overall anxiety, or just a little bit of a bump kind of in their overall well-being, or maybe a little reduction in pain. Usually I find around 20 milligrams is a good dose to sort of get some type of effect. But again, you may get a pretty good effect off of about 10 milligrams. And then, like you said as well, the combination of THC and CBD, I think it's almost still, I think, a little bit underutilized in some ways, because I think that people get very, very scared of using THCV, but they're comfortable with using CBD. And then some people too will get comfortable with using CBD in the day and then only THC at night. And I understand the strategies behind that, and sometimes I even use that strategy myself. But overall, if you're not combining both of the cannabinoids, and then when I'm saying both cannabinoids, I mean THC and CBD, then you're not going to get the experience that a lot of people are getting that are benefiting from. So I think it's important to use those cannabinoids together sometime at some point, in order to get the full beneficial effect. And then in terms of what's happening in the future with regards to terpenes, do you feel that that's something that people are going to be able to have more access to in the future? And what I mean by that is, like, do you feel that like these the LPs and people who are producing cannabis, do you think that they are going to label their products with the appropriate terpene content, or that happen?
Companies don't do anything that they don't, if they have to spend money on it, no. If they're mandated to provide the information, that's different. So I'm being quite serious about this, cynical but serious. I mean, I've been preaching this gospel for 20 years at least, and I don't know that. Well, the powers that be don't necessarily listen to me, but yeah, we'd like to see this more information available to consumers. We're also trying to provide the evidence of why there is the entourage and synergy. I'm collaborating with Ryan Vondre at Johns Hopkins, and we have studies combining THC with terpenoids, double-blind fashion with patients with vaporization. And we're trying to show salient differences that would help explain why we think things are the way they are.
Amazing. Well, I'm very much looking forward to that research. And I know we only have a few minutes left. There was one other question that I wanted to ask you before we go. So I believe you coined the term clinical endocannabinoid deficiency. Am I correct?
Yes, that one I'll claim.
So perfect. So I mean, I've said this to a million of my patients before, so the ones who are listening are probably gonna be laughing at me, but like, just like you can be deficient in vitamins, you can be deficient in hormones, you can also be deficient in cannabinoids. And that's something I think that's very, very surprising to a lot of people. And you've identified a few different conditions, migraines, fibromyalgia, IBS, and I always say to people, whether it's vitamin, hormone, whatever it is, if somebody's deficient in something and you correct it, you bring it up to the level, generally speaking, you do see a marked difference in improvement clinically. When you take something that is already at a normal level and you bring it up to an optimal level, yeah, sometimes you do notice a pretty big difference, but not quite the same as when you're deficient and you go to normal. And for me, I look at migraines, and I have so many patients that have told me, like, when I use cannabis, it's not like it takes my migraine from a 10 to a 5, which is sometimes what NSAIDs do, like things like ibuprofen or also too, even like the triptans, max salt and that kind of thing. They might take it from a 10 to a 5, but a lot of people will say that when they use cannabis, it takes from like a 10 to a 0. And for those people, I'm just thinking that may be a patient who's just deficient in cannabinoids to be able to get that much of a clinical effect, like almost instantly, like right away. So I was just wondering, if you could speak a little bit on clinical endocannabinoid deficiency.
Sure. So the concept came from just that idea. We've got all these disorders at the most simplistic level. In Alzheimer's disease or dementias, there is a deficiency of acetylcholine, the memory molecule in the brain. We try to increase that. In Parkinson's disease, there's inadequate dopamine. In depression, you try to increase the amounts of serotonin, although it's much more complicated than that. So I hypothesized, why wouldn't there be deficiencies of endocannabinoids? And if there were, what would it look like? Well, you would have somebody who had pain. They might have nausea. They'd have an upset gut. But the common thread is pain. And so, I really honed in on migraine, fibromyalgia, and irritable bowel syndrome. And these are what are called comorbid conditions, meaning they tend to happen in the same people. And God forbid somebody has all three, because she will be labeled by her male doctor as hypochondriac. But my firm belief is this has nothing to do with psychology. It has everything to do with biochemistry in the brain. So I developed this theory about 20 years ago, more than that now. But it's really been borne out experimentally. There have been studies, for example, in migraine, where they did lumbar punctures, spinal taps on people, and showed deficiency of anandamide in migraine people, very statistically significant compared to people who didn't have it. I was interested in doing this study 20 years ago, but we could never get it through an ethics committee. However, they did get it through ethics in Italy. So, it's nice to see that corroborated. Likewise, it's been known for 70 years that electroconvulsive treatment, so-called shock therapy, can be very effective in people who are desperately intractable to treatment of their depression. So it's not something I'm advocating. It's only for the worst of situations. But shock therapy does two things. It lifts the depression, and it also produces, hopefully, a temporary memory loss. So what's that sound like? It sounds like THC. So I had hypothesized years ago that the way that ECT, shock therapy, works is by boosting endocannabinoid levels. Well, it turned out a few years ago, they demonstrated that very thing in Germany. The lower the anandamide levels, the worse the depression was, and the better the improvement was with the number of shock treatments that were given. So again, I'm not advocating shock therapy. I'm saying that we're finding corroboration for this concept of clinical endocannabinoid deficiency. And it's certainly, that can be dealt with two ways. It can be dealt with through lifestyle changes, aerobic activity, sleep regulation, and particularly diet, non-inflammatory diet with prebiotics and probiotics affecting the gut microbiome can do wonders for the endocannabinoid tone. And then a quicker way is by using cannabis-based medicine to supplement what's missing. So again, there are different ways to approach the same kind of problem. It doesn't always have to be cannabis, but when needed, it can be extremely effective.
Well, I really appreciate you saying that, because I think a lot of people listening to this, or I hope anyway, are also into their health. And I'm very much into my health and other aspects outside of cannabis. I try to take care of my diet and exercise and sleep well and that kind of thing. So, a really good point to tie in there. I really hate to do this, Dr. Russo, because I've really enjoyed chatting with you today, but unfortunately our time is up. I'm sure people really enjoyed this conversation and would like to know more about you. So where can they find you online, and where can they read more about you and your work?
So there's a library of my articles and book chapters at ethanrusso.org. And they can find out about Credo Science at credo, credo-science.com. So those will work.
Excellent. Well, thank you so much again for joining us today. It's just been an absolute pleasure to chat with you. I've certainly learned a lot. You shared a lot of fantastic information. So thank you so much again for coming on, and thank you everyone for listening. And we'll be back again next week.